This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. Welcome to episode 111 of the Psychcast by MD Edge. In this Masterclass edition, we welcome Dr. Jay Shore for a topic that is all too important right now, telepsychiatry. Dr. Shore will lecture on the best ways to handle your patients electronically. In the age of COVID-19, telepsychiatry has perhaps never been more important. We are all well aware of the mental health fallout that's happening now and is going to continue to happen into the near future. So without further ado, let's jump right in. Please welcome Dr. Jay Shore.
Hello, my name is Jay Shore. I am a psychiatrist and I am Director of Telemedicine for the Arthur and Helen E. Johnson Depression Center, as well as Director of Telemedicine Programming at the University of Colorado Anschutz Medical Campus Department of Psychiatry. I'm recording this Psychcast Masterclass on direct-to-patient in-home video conferencing. Before we get started with the content, I have a few disclosures. One, I do some work for multiple organizations in the realm of telepsychiatry and telemental health, but I'm solely responsible for the content of this presentation, and it doesn't represent any official policy or endorsement or opinion of any of the organizations which I'm involved. I'll be presenting some legal and regulatory material, and that's presented as information only and not intended to represent legal or regulatory advice. Individuals should seek consultation through their specific organizations. In terms of disclosure, I also work as Chief Medical Officer for AccessCare Services, which provides telehealth and technology services in Colorado as well as Alaska. And I've received royalties from the American Psychiatric Press and Springer Press. In addition, before I begin my discussion, this tutorial is really to help people rapidly get familiar with some of the highlights of video conferencing in mental health, or what's often referred to as telepsychiatry. And it's really in response to the COVID pandemic and the need that many people are having to socially or at least physically distance themselves. It's not intended to override other guidance or policies and organizations, and that people should be aware we're in a very rapidly evolving regulatory environment. I'll talk about some of the changes that are being impacted in terms of telepsychiatry in COVID. But people should be aware that and stay up to date on how regulatory barriers are decreasing, but may increase again depending on emergency declarations and status. So with the remaining time, I tend to break up in my mind doing telepsychiatry into three major areas: administrative considerations, technological considerations, and clinical considerations. So I'll review each of those areas, and I'll conclude with the discussion of further resources that are available that could be helpful to people. So we'll start with administrative considerations when conducting telepsychiatry and beginning to use video conferencing to see patients. One of the important and key administrative considerations is licensure that often comes up, and generally psychiatrists, medical doctors need to be licensed in the state where a patient is physically located at the time of the video conference. Although there are exemptions for providers working in federal systems, which if you're working in the VA or the Department of Defense or Indian Health Service or other federal system, there may be some state licensure exemptions that you can look into. Notably, during COVID, some states are modifying the restriction of needing to be licensed in their state when seeing a patient located there. So providers should specifically look, if they do not hold a license in a state where a patient is, they should default to needing to hold a license there, but they can look either at the licensing website of that particular state, and also the Federation of State Board of Medical Examiners has updates and informations about COVID-specific exemptions. In addition to licensure, your malpractice company should be aware that you're doing telemedicine and telepsychiatry. Many don't require any additions, or many policies may already cover that. Some policies may require an additional rider, and some insurances may not cover it, and you may need to get a specific telepsychiatry policy. I know that the APA, as an example, I believe their insurance offers a specific telepsychiatry policy, but there are others out there in the market as well. And then the other big, one of the other big regulations is understanding the prescription of controlled substances over telemedicine. There is an act called the Ryan-Haight Act that that basically is a complicated act, but to simplify it, it requires that if you're going to prescribe a controlled substance to a patient, you need to see them in person first, and then, as good practice, at least once every 24 months to be fully compliant. There's a number of details and exemptions within that act. Notably, during the COVID-19 crisis, the federal government, as of March 17th, waived the Ryan-Haight Act, meaning you can prescribe controlled substances during the COVID emergency without an in-person exam. The presumption is that that requirement will come back when the emergency declaration is ended. And also, this does not address the need to comply with individual state rules and regulations around telemedicine and the prescription of controlled substances. Some states don't have any additional regulations, some states do. So both before and after COVID, being familiar with both the current federal guidance as well as the state guidance is important. Administratively, telepsychiatry services should have a procedures and protocol, and this is really a standard when doing telepsychiatry. There are examples out there and discussions of this on various websites. Again, I'll refer people back to the American Psychiatric Association. They have a telepsychiatry toolkit web page, which can help provide guidance there. The American Telemedicine Association also has some good guidance documents about what needs to go into a protocol. Generally, protocols spell out things like workflow for the clinic, how patients are scheduled, billing, documentation, as well as addressing psychiatric emergencies that may occur. This is probably one of the most common questions that comes up with people new to telepsychiatry: how to manage and handle psychiatric emergencies if a patient becomes suicidal, or maybe have thoughts or threats to harm others, or gravely disabled. How do you deal with it? And so one of the first things is, again, within a clinic protocol or procedures, or an individual practitioner's protocol for telepsychiatry, they should define first what would constitute an emergency, and delineate procedures for that up front. And then they should make sure to educate the staff they work with and their patients about these, and particularly the patients when they're registering in the clinic or the initial telepsychiatry session. And some of the basics, of course, include when you're starting a session, particularly directly into a patient's home, knowing their location at the time of the session. Sometimes patients will change locations of homes, and not uncommon for patients to travel on vacation and wanting to do a telepsychiatry session with you. And that's also where state licensure can come into play, knowing where they're located at the beginning of a session. Documenting how to get a hold of them in case you lose the connection is very important. In your emergency protocol, knowing how and when to contact local emergency services, and how to access and work with those. 911 is often a local call that's keyed into someone's cell phone. So if you're a provider and you're calling 911 to get support for a patient, you need to identify the location. Many states have websites which list the local county numbers of the emergency response. So you can, instead of calling 911, you can call directly into the county where the patient's located to speak with emergency responders. Another tip for dealing with emergency procedures: if you have a patient that you're working with that you believe is at higher risk for needing to be managed in terms of an emergency, then the American Telemedicine Association and the APA guidelines suggest that you consider using a patient support person. A patient support person, or what is termed a PSP, is someone who is there and present in the location with the patient, most often a family member or a close friend, that you get a release of information from the patient and pre-consent to be able to contact them in the event of an emergency. Then if an emergency situation arises, you can work with the person who is on site with the patient to arrange further disposition, contact with emergency services, or take care of other needs that may be warranted on site. So that was a brief review of some key administrative issues to consider. Let's move on to technical considerations. So obviously, some of the basic technical considerations is both the provider and the patient need a video conferencing system that renders adequate audio and visual signal, which requires adequate bandwidth to do so. There's a huge number of video conferencing platforms that are available on the there's both freeware and commercially available video conferencing software that providers can explore. Obviously having software that is HIPAA compliant is important, as well as that has the appropriate level of security and encryption for the transmission of video conferencing. Providers should recognize that HIPAA is really a process. It's not just that you have HIPAA secure encrypted software or equipment, but that you use that equipment in a manner that is compliant with HIPAA policies, either of your individual practice, or of your organization. Providers may be aware that during the COVID emergency declaration, the Human Health and Services Office for Civil Rights has come out with a statement that says they will exercise enforcement discretion and waive penalties for HIPAA violation against healthcare providers that serve patients in good faith through everyday communication technologies such as FaceTime or Skype during the COVID-19 national public health emergency. I think the key wording here around this HIPAA is not that HIPAA is being waived. It's that that the federal government will exercise enforcement discretion. So my recommendation is to providers, if they have HIPAA compliant software, to use that as a first line and only go to technologies, everyday type technologies like FaceTime or Skype, if they're unable to make an adequate connection to do video conferencing with the patient with the first option or selection. The other thing worth mentioning technically during the COVID emergency is that many providers and clinics and psychiatric organizations are not only having to turn to video conferencing for their patients, but they're having to do remote teleworking and virtualize their entire operations. And that is different than just doing telehealth. Doing telehealth is using this technology to render clinical care. Virtualizing your operations means adapting your complete operational clinical workflow to a home and virtual environment. It requires additional technologies and platforms, shared EHR, scheduling, operations, and some of the important principles in doing that is trying to the KISS principle, keep it simple, stupid, is to take your in-person operational workflow and to try and replicate it virtually, and making sure that there are clear delineation of people's roles and responsibilities and how the workflow will work in a virtual environment. And it's been amazing to see during the first couple weeks of the COVID emergency how rapidly and how many organizations have been able to completely virtualize their services so people are no longer meeting in person. Moving on to the final area of clinical considerations is a couple really important concepts, particularly for providers not used to working under video conferencing. All of us, in the way our society is being virtualized and the changes in society in the last decades with technology, I think we're all moving to what is termed hybrid relations. And this means that we hold relations with human beings in multiple mediums and spaces. We have relationships in our personal lives, both in person, over telephone, over social networking, over texting, over email. And in our professional lives with our patients now, we interact with our patients not only in person, but we are now interacting with them, of course, over video conferencing, patient portals, texting, email, phones. And so these hybrid relationships can be new to some practitioners about how to manage them. And within that, within hybrid relationships, there's this concept of virtual space. This space we interact with people that's not in person. And there are certainly there are significant differences between interacting with patients and others in physical versus virtual space. Starting with physical space, it's really been the traditional gold standard of how to interact with patients. There's an immediacy and trust in interpersonal interactions when being in the same room with someone. The physical boundaries of being in the same room with someone can set sort of a therapeutic frame. And there is a lot of research, practice guidelines, um, decades and literally centuries available about how to work with a patient in person. Virtual space is relatively new over the last 2 decades, although there is a growing body of work, evidence, and research telling us how to do it. Some of the advantages is that it can be convenient and immediate. Um, it may create a little more sense of space for the provider and the patient. That sense of space for the provider can help them gain a little bit of what you would consider maybe an observing ego in the clinical situation. For patients, it may give them a little bit initially of a feeling of distance, emotional distance from the provider, but it may help patients, particularly with PTSD, anxiety, other avoidant behaviors, feel more comfortable and more control on their end of the therapeutic session and allow them to engage more in treatment. It's certainly you can offer more flexibilities and off hours care, and especially treating patients in their homes. You are rendering treatment in the environment in which a patient lives, and it gives you a little bit more information. Not only are you seeing how the patient's dressed, but you're getting to see their home environment, and may help you with assessing the patient and developing more specified treatment. So it may also, for the patient, decrease stigmatization because they're not having to come into a specific clinic. So again, may decrease that barrier to care, and it may make them, that virtual space may allow them to open up a little bit more. There's a term called virtual disinhibition that you often see with technologies, where people tend to be maybe a little more open than they would be in person. So those are some of both the risks and the downsides and the upsides of virtual space. Some of the basic do's and don'ts when video conferencing is making sure that the room that the provider is working in is secure and private with doors and windows closed. And that's true for the room that the patient's in. Making sure that you always introduce others in the room with you or ask to be introduced to anyone in the room with the patient. Make sure they're in line of sight. Sometimes you can be video conferencing with a patient and not see everyone in the room, so you may want to set that up front when you're meeting with patients. Keeping the room well lit on both ends, so the patient and provider can be seen. Making sure the webcam is placed appropriately above the computer screen, not below or on the sides, so there's a good eye contact between the provider and patient. Not sitting too far or too close to the camera. Your head should take up about 2/3 of the screen. And then I think one of the most important things to remember is that often, as a provider seeing someone over video conferencing, one may feel that you have less control over the clinical setting. I sort of feel that you give up the illusion of control. I would argue that one doesn't have any more control when you're seeing a patient in your office. And so providers need to make sure that they're actively managing the room and the setting. And so that means not being too passive over the video. If you need a patient to close the door, create more privacy, or need to be a directive, ultimately the provider is responsible and should be proactive. In terms of adapting a personal style to video conferencing, you want to animate yourself a little bit more than you would in person to come across the screen. You want to use picture-in-picture to watch how you're coming across on the other end in terms of your body language and perception, where your gaze is. It may be necessary to increase the small talk a little bit, not disclosing anything or crossing any boundaries with conversation, but doing things like asking about the patient's environment and setting, not only the room they're in, but what may be going in, particularly if they're not located in the same city as you. For example, what their current weather is, what's going on in their home environment. Really working to bridge that virtual gap and make that connection over video. And then, as always, as you would in person, having a very active listening stance and having a lower threshold to inquire how the patient's doing, how they're feeling about using video conferencing. If you're feeling, if it's difficult to read someone's emotion, asking them, just checking in. Hey, I noticed, are you feeling a little sad? It looks like you're feeling a little sad. So a little bit more active inquiry can be helpful. So I hope that this discussion has been helpful in terms of some basic orientation to video conferencing. As I had mentioned throughout this discussion, some resources that are very helpful are the American Psychiatric Association's Telepsychiatry Toolkit. It's got a member-facing side, but also a non-member-facing side with a lot of resources available. The American Telemedicine Association also has a number of those resources and links. So those are good places to start to get additional information, as well as the research literature. Like I said, there's a large literature that's instructive on how to do this well, including the 2018 joint APA and ATA guidelines document, which is a brief document that summarizes over 40 or 50 different guidelines and about 5 or 10 guidelines from those organizations on video conferencing. That's another helpful resource.
And that concludes episode 111 of the Psychcast by MD Edge. Let's get to this week's credits. The Psychcast is produced by Gina Henderson and Jeff Bauer. Our host is typically Dr. Lorenzo Norris, the editor-in-chief of MD Edge Psychiatry. Our Masterclass lecturer today was Dr. Jay Shore. Our show notes this week were written by Dr. Jacqueline Posada. The Psychcast is produced by MD Edge and Medscape editor-in-chief Dr. Ivan Aransky, as well as MD Edge executive editors Mary Ellen Schneider and Kathy Skarbeck, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MD Edge podcasts, Nick Andrews. This is the Psychcast by MD Edge.